Good morning, my name is Camilo Benavides and today I'm going to show a lecture entitled The Ninth Syndrome with Upward Gaze Palsy After Resection of a Pontomesencephalic Cavernous Malformation. Brainstem syndromes constitute a special clinical entity due to the complex array of neurological signs involving cranial nerve nuclei and projection fibers. The ninth syndrome is defined by the presence of complete horizontal gaze palsy ipsilateral to lesion and contralateral adduction gaze palsy, also known as 1.5 syndrome, peripheral type facial palsy and hemiparesis, hemianesthesia, or hemiataxia. Here we present a case report with this unusual syndrome. A right-handed 57-year-old female presented to the emergency department with headache, emesis, right hemiparesis, and ataxia for 15 days. MRI showed a giant pontomesencephalic cavernous malformation. Resection of the lesion was done through a suboccipital midline craniotomy and a talopellar approach. The suprafacial collicular zone of dorsal pons was used as a safe entry zone. The last picture shows the proximity of the lesion with the medial longitudinal fascicle, facial colliculus, and facial nerve fasciculus. The post-operative evaluation revealed a left-sided horizontal conjugate gaze palsy, a left-sided internuclear ophthalmoplegia, a left-sided peripheral facial nerve palsy, a right hemiparesis, and an upward gaze palsy. So the ninth syndrome plus upward gaze palsy was diagnosticated. Images A, T1 with contrast, and B, SWI show the lesion pre-surgically. A giant Zabransky type 2 popcorn-like pontomesencephalic cavernous malformation with bleeding in multiple stages is noted invading almost all the circumference of the pons and lower midbrain. Images C, T1 with contrast, and D, FLAIR, show the postoperative period. A gross total resection of the lesion and edema and midbrain tegmentum are noted. Outcome. On hospital discharge, Glasgow outcome score was 4, indicating moderate disability. Rankine modified score was 2 points. On 6-month outpatient clinical follow-up, the gaze and facial palsy and corticospinal tract signs had recovered. The image shows the main structures involved with gaze control. At the supratentorial level, the main structures are the middle frontal gyrus and the parietotemporal junction. At the level of the mesencephalic tegmentum are the nuclei of the mesencephalic reticular formation, the third and fourth cranial nerves, which participate in vertical conjugate gaze. At the level of the pons are the paramedian pontine reticular formation, the medial longitudinal fascicle, and the nucleus of the sixth cranial nerve, which participate in the horizontal conjugate gaze. Historically, Freeman in 1943 was the first who described the damage of MLF and PPRF, but was Miller-Fisher in 1967 who gave the name of 1.5 syndrome to Freeman's findings. Since then, many variations of the syndrome were described. Eggenberger in 1998 described the 8.5 syndrome when peripheral facial nerve palsy was associated with the 1.5 syndrome. And finally, Rossini in 2013 gave the name of the 9 syndrome to a subtype of the 8.5 syndrome. In 2018, Xue did a search in PubMed with the term 1.5 syndrome. He found only 2 articles involving the 9 syndrome, which shows how unusual this syndrome is. The 9 syndrome is one of the variants of the 8.5 syndrome, which has different subtypes. First, the classic 8.5 syndrome with 1.5 syndrome plus ipsilateral facial palsy. Second, the 8.5 syndrome variants, which includes the 8.5 syndrome plus vertical gaze palsy or bilateral gaze palsy. And finally, the third, the 8.5 plus syndrome, which include the 9 syndrome and other variations. The pink color shows the component of our case report. So, the 9 syndrome plus upward gaze palsy was presumably due to the compromise of left paramedian Pontine reticular formation, ipsilateral internuclear fibers of medial longitudinal fasciculus, nucleus or fasciculus of the facial nerve, descending corticospinal tract fibers, and finally midbrain reticular formation damage. Take-home message: we report a rare variation of the recently described 9 syndrome. Clinical examination and imaging are mandatory for diagnosis. Cavernous malformation are one of the causes of this clinical syndrome. Surgical treatments are the mainstay of therapy for this pathology. And finally, complete recovery is possible following the safe entry zones for brainstem surgery. Thank you very much.